Unfortunately, we're one board member short of a quorum, but I would like to proceed with the meeting as far as presentations and discussions on topics. However, unless or until we have a quorum, we'll be unable to deal with any action items. But Liz Warren, I know you're here. If you wish, I would like for you to do your presentation on the ombudsman work group, but I'll defer to you if you wish to do it during when we have a full meeting. But that's my preference going forward. I want to honor the fact that folks have come here, taken time out of the schedule to be here, both in person as well as remotely. So moving forward, and if we get a quorum, then we will proceed according to the agenda. So because the agenda is an action item, we can't approve the agenda, we can't approve the minutes or any other action item that's listed on the agenda. So moving forward, since we have an interpreter here, if the interpreter can advise us of the interpretation functions.
Good afternoon. We are Priscilla and Lorena, and we will be providing simultaneous interpretation services for the meeting today. So you can access interpretation services by clicking the globe icon in the bottom of your screen and then selecting either English or Spanish. Everybody should select a language. We do ask that when speaking to please be mindful of our simultaneous interpretation, to speak slowly and clearly, and to try to avoid interrupting or speaking over another speaker. We will signal you with the raise hand symbol on Zoom if you are speaking too fast and need to slow down. We will signal you by turning on our cameras if you need to speak and enunciate clearly. And please pin us on Zoom so that you can identify us as your interpreters. Thank you for keeping us the service in mind while conducting the meeting.
Thank you.
Now I shall say it in Spanish.
Oh, thank you.
Buenas tardes a todos, somos Lorena y Priscila y vamos a ser sus intérpretes en la reunión de hoy. Pueden acceder a los servicios de interpretación haciendo clic en el icono con forma de globo en la parte inferior de sus pantallas de Zoom y seleccionar inglés o español. Todos deben seleccionar un idioma. Les pido que cuando hablen tengan en cuenta la interpretación y que lo hagan de forma clara y lenta y eviten hablar encima de otro orador. Utilizaremos la función de levantar la mano si están hablando muy rápido o encenderemos nuestras cámaras si necesitamos comunicarnos con ustedes. Pueden fijarnos en sus pantallas de Zoom para identificarnos como sus intérpretes. Gracias por tener en cuenta los servicios de interpretación mientras conducen y participan en esta reunión. Thank you.
Thank you. Good afternoon, everyone. Once again, my name is Michael Rodriguez. I'm the chair of the Behavioral Health Advisory Board and appointed from District 5. And so I'm going to ask everyone to introduce themselves and then we'll go to Janice.
Hi, I'm Janice Gardner. I'm from Supervisor Long's district, and I am the chair of the prevention committee.
Nancy Borchard.
Nancy Borchard, I'm Supervisor Long's appointee as well as a family member and a member of the adult committee.
Thank you, Elizabeth Stone.
Good afternoon. My name is Elizabeth Stone. I was appointed by Linda Parks prior to her turning out. One of the perspectives that I represent is the person of lived expertise, having been diagnosed and spent time in psychiatric hospital. I'm also currently a member at large on the executive committee and chair of the CHADE committee and participating in the suicide prevention efforts.
Thank you. Claudia Arman.
Claudia Arman, I'm in District 1, Matt Levere's district, and I'm a family member.
Thank you. Cheryl Heitman.
Good afternoon. In District 1, Matt's district, and I'm a member of the Family Management Services.
Supervisor Matt Levere.
Good afternoon, everyone. Matt Levere, representing the Board of Supervisors.
Nomi Maruso.
Naomi Marufo, appointed by Supervisor Long.
Thank you. Diane McKay. Welcome.
Thank you. I'm Diane McKay. I am representing Area 2, Jeff Burrell. This is my first meeting, and I'm happy to be here. Well,
Thank you. Liz Warren.
I had to be unmuted. I apologize for the delay. My name is Liz Warren. I'm the Executive Director of the Client Network. I represent District 5. I sit on the Prevention Committee and the QMAC Committee. Thank you.
Thank you. And it's my understanding we did not receive any written requests for public comments. But it's my understanding there's at least one or more people in person who wish to make a public comment.
Yeah.
And so I'll start with you, sir. So you can move, where, Jackie, where should you go? Okay, so if you wish to either go over that side or this side. So that the microphone will pick you up.
Do I sit down or?
Yeah, either way, whatever you feel more comfortable.
Okay, my name is Martin O'Doherty. And my wife Patricia O'Doherty is here with me. I appreciate the opportunity to talk to you guys regarding our daughter. Most, or at least some of you, received an email from us on January 30 and again on March 16 regarding our daughter Annalise O'Doherty. Our daughter Annalise is currently residing at View Heights Convalescent Hospital in South Los Angeles. She's been there for almost 2 years. We are here today to strongly request that she be relocated to one of a number of more suitable facilities in Ventura County. Prior to her move to View Heights, Annalise was located at Anca, Casa de Esperanza, and a boarding care. It was clear to us, and I'm going to say obviously the VCBH decision makers, that she was making satisfactory progress, and just because of a minor incident while at the boarding care, she was sent to a highest level of care facility. We strongly disagree that this was the correct decision to be taken by VCBH. And we now know that it was a case of finding a vacant bed, no matter what kind of facility it was. We feel that Annalise would have been much more suited to a facility such as Casa de Esperanza, or at most Hillmont House, but not View Heights, where in our opinion, she regressed due to lack of proper psychiatric and psychological care, as well as, I'll say, the general environment and makeup of the residents. For example, she is encouraged to attend group sessions for alcohol addiction. Our daughter, I won't say never tasted alcohol, but doesn't drink at all, never has just about. We also disagree with a comment, this is more important, was from VCBH that Annalise stated that she was not ready to move from View Heights. We do not agree that Annalise knows what's best for her mental health progress. We are again asking that our daughter be moved without delay to a facility that would help her progress to a level that we believe is possible. We understand that Annalise is over the age of consent, but she is our daughter, and we will fight for her well-being as long as we are on this planet. And so this is my first time being here, and we appreciate the fact that there is an audience for us, somewhere to turn to, and all that is being done. And we understand that it's not so simple, but we are asking, please give our daughter, your attention and do what is best for her. Thank you so much for giving me this time.
Thank you. And Mr. O'Doherty, just so you know, we can't comment on a specific case as a board, but I know we have a staff member here from VCBH, both here in person as well, remotely, and they will take your comments into consideration.
Thank you so much. We appreciate that.
You're welcome. Any other public comment at this time? Correct. Third comments. Welcome again, everyone. I'm Michael Rodriguez. In addition to being the chair of the Behavioral Health Advisory Board, I'm also the Chief Deputy Public Defender, where I manage public defenders specialty units, including mental health, criminal justice, mental health, juvenile delinquency, and probate conservatorship. I want to welcome everyone who's here in person, as well as everyone who's here remotely. Appreciate your time and your willingness to assist us in improving meaningful access to behavioral health treatment that's appropriate to each and every individual's needs. And one of the things that I wanted to talk about in an executive committee meeting, I said I would, and I had to look at my notes so that I remembered exactly what I said I was gonna mention during my comments, which is that we're transitioning now into, as you know, and we're seeing some hiccups right now with lack of quorum, but we're transitioning from the height of the COVID pandemic, where everything was remote and folks, policymakers, everybody had to, learn on the fly, transition on the fly for a pandemic that hadn't hit in over a century. And so there's a learning curve when we transition into going remote, and just like I trust it's going to be kind of like a curve, a relearning curve of getting back to post or not as intensive pandemic meetings. So one thing that's important for members, and I would ask, is that we value each and every one of your participation here, and we honor and respect and encourage your active participation in board business, because it's us working together, whether we're standing at different, we all have our different perspectives and different viewpoints, and we may disagree going in, we may disagree at the conclusion of a discussion of an issue or issues, but it's important that each and every one of us come together so that we can put all our perspectives on the table and hopefully arrive at informed decision-making process. And the other thing is that there's a lot of things that require participation from board members, such as site visits, which we're going to reinstitute after about a 2+ year hiatus. We have the annual report that we need to complete. So I'm inviting folks to participate in that work group, which we formed last month. Because it's important that the more people that we have sharing in the labor, the more effective we can be as a board. So I want to thank each and every one of you once again for joining us. I would also ask each and every board member, whether you're here today in person or remotely, or watch this later on, is to reflect and examine your capacity to meaningfully participate in board duties, so that you can move forward and so that you can raise the bar on the type of treatment, and not only the type, but the qualitatively and quantitatively the treatment that's given and provided to those in need in this county. So thank you. We're not going on a formal agenda. I'm just kind of listening to that guy. So directors report.
Sure. So a couple of pretty big happenings that I want to bring all of your attention to. And I think just to start off, my written report is in your packet. I think it starts on page 2 there. There's a lot of really exciting things that are starting to happen. Just a couple of examples is we received notice of an allocation. It's not a competitive grant of $13.2 million for bridge housing. And so our staff is working right now with staff out of the continuum of care for the homeless, out of the CEO's office and others to put together a proposal for how we might use that funding to expand a whole variety of options for individuals. And it could be vouchers, rooms, they're calling it tapestry or a quilt of going through and finding where there's the biggest holes and valleys of additional housing. So it's still being developed, but we'll keep you in the loop as that happens. The other good news, if you might recall, when the governor's budget was signed, there's a new provision where counties are held financially liable for sending individuals to state hospitals for incompetency to stand trial, or having just too many people in general sent to the state hospital. We have a cap. Anything above that cap, you have a financial penalty. And the penalty is repayable to the counties at some point down the road to fund services that would keep people from the prison system. So it's a penalty, but it's also a way to get us off focus. In addition, the state put out, and again, this is county allocations. Our county is eligible for just over $8 million. Again, the proposal would be to do community-based felony income stand trial restoration. So Dr. Shipper is working with a group of our criminal justice partners, including the court, the DA, the prosecutor, the sheriff. Everybody has to be on the same page because this is bringing people into the community for community-based restoration. If we don't have the support of all of the key stakeholders, we're not, first of all, it's not going to work. Second of all, we're not eligible for the money. And so, so that's also in progress. I put in your packet a couple of legislative things that are hot right now. And the first one that I want to draw your attention to is on page, let's see, it starts right after my report on page 7 of my report. Senate Bill 43, introduced by Senator Eggman. Our state association has gone on record of opposing that. It puts in play the concept of grave disabilities for individuals who suffer from substance use issues. And, you know, my personal opinion is some states have found a way to insert this into their treatment continuum in a way that works. This particular bill is extremely wide reaching, and essentially anyone who has ever had, well, quite frankly, the way that it's written, pretty much anyone who's ever had an issue with substance abuse, whether they're intoxicated or not, would be eligible for a petition under this bill. So we're opposing the criteria, hoping that we can find some lemonade in this one with Senator Eggman. And you'll see all of the issues that the state association put in my report.
Petition, you mean 5150?
Mm-hmm. Yeah, it would be similar to a 5150. The whole issue of involuntary substance abuse treatment, whether it even makes sense, continues to be a hot topic of debate. You know, the evidence doesn't necessarily support that that's the best way to have really good outcomes. And so that's also in play. Lastly, you know,
On that one. Is the opposition kind of based on the fact that it's too broad? Because I think everybody would agree that there are some people where substance abuse does cause them to be gravely disabled. The ones who are in the middle of those rows of abuse. I agree. If it's anybody who's ever used, too broad, right? But so it's the goal to maybe narrow the definition in this bill, because it seems like it could serve some purpose. I saw the point that they're worried about it causing some people to not seek treatment. But I think how many of those people who are in the middle of an action are actually proactively seeking treatment? And so there has to see, so is the goal maybe to just still push the bill forward with a more narrow scope, or
with,
you know?
I think the opposition was going officially so that we could start the negotiation process.
Okay.
So and like I said, I've looked at I think Florida is an example of a state that has a pretty robust involuntary set system. The other piece of it, though, is we have to build out the capacity and have places for them to go. And so passing the law without any place for folks to go is a problem. It's true.
I think also I had read or heard that there is some talk among some people about just the whole thing gravely disabled and trying to hone in on that a little bit. I realize this is a whole different part of it, or just a part of it. But, you know, it's interesting how counties in California, what they consider gravely disabled and what they're doing with it. LA County is much stricter, their definition of gravely disabled, really, I think, is maybe more useful than perhaps ours. Ours is a little bit, the bars a little, I know you and I talked about this, but the bars a little bit lower. And anyway, I'm just wondering if there's anything at the state level where there's some kind of move on to try and define that a little better and maybe make it more uniform among counties.
Yeah, I would say the LPS law or, you know, the entire gravely disabled topic is under the microscope from a lot of different angles.
Yeah.
You know, and last year there was a huge run at that, even with airports and, you know, different advocacy groups coming to the table, you know, with different points of view. Some want stricter, some want, you know, not at all. So it's a very hot topic. I think we're gonna see bushel baskets full of bills introduced, you know,
Okay.
this year.
And is your organization, sorry, just one follow-up, is your organization working on that?
Yes.
Is your statewide organization?
Yeah, our state association, we actually formed a special committee just to, because there's so many that came out last year and we're anticipating the same. We had to restructure our committees at the state association so that we had a group that could just really robustly go through them, you know, and contract it for us.
Right, yeah,
Yeah.
that's right.
Because this is the time, you know, I mean, you know, so much focusing in on homelessness across the state and what our role is.
Yeah.
In that.
Right.
And there are times where our hands are completely tied. You know, I think most people in the room would agree that this is not appropriate. But there's nothing we can do legally, you know, to leave the person there. So.
And what I've seen, and because we represent folks who are gravely disabled, and there's been petitions filed, and we also represent folks who are incompetent to stand trial, who are languishing in the jails, even though they have improved treatment in the jail's still not a hospital. And we have our clients sitting in jail much too long, and it's not because that there's for lack of legal mechanisms to get them into facilities or hospitals. Is the lack of space, the lack of facilities is what is the biggest holdup. More than anything else, what we see time and time again. And so my thing has been, when we've talked about changing the definition of gravely disabled, is that it's a supply and demand. We have plenty of demand. The demand exceeds the supply of the infrastructure that's available. So we have to invest in the supply of treatment, both for crisis care and then all the step downs down to community based outpatient treatment. And until we get there, like, to me, it's like we're barking up the wrong tree. I know other folks disagree with me. And that's part of, like what I said, it's like we all sit at different perspectives, and I think that almost everybody's perspective is valuable and valid. And what I see is that it's lack of infrastructure. The other issue that I personally have is this, as far as using hearsay to justify an involuntary commitment, which I think runs about for, you know, Sixth Amendment Confrontation Clause, those kinds of things. But I don't want to get to you. I see Mary Hafner has her hand up, and then followed by Elizabeth Stone. Nancy.
Okay, first of all, thank you for taking my question, and it's good to see everyone back in person. I wanted to address what you are all talking about right now, Director Gilman and Michael Rodriguez. Did either of you see the press conference yesterday in San Diego that included Gavin Newsom, Sacramento Mayor Darrell Steinberg, Tony Atkins, who's the president pro tem of the California State Senate, San Diego Supervisor Nathan Fletcher, and the local NAMI there? They talked about the new bond measure that Newsom is putting forth next year to fund more housing and supportive services. They plan to add an additional 60,000 beds along the continuum of care. So, I mean, I'm just wondering if that's going to be a topic that you're going to be discussing. If so, I won't say anything further, but I do have information about that press conference if you would like to hear that.
Yep, I have talking points. That would be actually next.
Okay. Okay.
Alright, before we move into that, I know Elizabeth Stone had her hand up, and followed by Nancy Borchert.
Yeah, 2 points I'd like to make, thank you. And I just also want to clarify, in addition to having lived expertise, I've worked as a provider for more than 2 decades and as a credentialed addictions counselor, as well as residential counselor, case manager, so I've actually sat on both sides, right? But for stigma busting reasons, I like to start with my lived expertise. So I totally echo Scott and Michael in terms of I do a lot of outreach with individuals that are currently unhoused, frequently talking with people that are under the influence or actually maybe in a state of psychosis. And when you connect with someone, they are willing to go into treatment. So I really am sick of hearing this treatment resistance stuff. It's really disrespect resistance, right? And we don't have sufficient facilities, right? We really, really, really need co-occurring disorders, which is somebody who has a mental health challenge, frequently triggered by substantial trauma experiences in childhood, that are using substances, and once they're unhoused, it just gets all messed up, because if you're on meth, you can stay up all night and nobody can rape and attack you, right? And then you're sleeping during the day and the cycle just continues. Many of the people I've spoken with and connected with would love to go into treatment. There's no place that actually addresses those issues in our county. And again, if we're talking about resources, sending people out of county, as this family's kind of shared, that puts a burden on our system in multiple ways. And I would also just like to give an example of someone whose identity I'm not sharing. And I've heard this multiple times from individuals whose primary addiction is alcohol. And we kind of forget that people die from detoxing from alcohol if it's not medically supervised. But people whose primary addiction is alcohol, as well as having mental health stuff, are being sent to drug treatment programs that focus on opioids and sometimes meth. And there's this very big disconnect, because it's while they're addictive behaviors, there's very different experiences and things about that. That's why there's AA and NA. Right. And so also for people that have had a trauma history, being in a room around other people, when you're sleeping with multiple people in a room, like if there were 2 people in a room, it's kind of different than if there's 4 or more people for someone that is in treatment, and a lot of the stuff's coming up. So I've spoken with many people that it kind of got convinced to go, and the experience was just too overwhelming because the supports weren't there to match what they needed. So I just kind of want to share that I totally share people's concerns about not leaving people on their own. People have heard me very frequently talk about, like, let's not, benevolently neglect people, but then let's not let them get to the extreme where they're in some locked facility, if it's incarceration or an inpatient unit, and really trying to meet people in the middle, but we need the services to do that. The second thing I would just kind of like to share, and this might be more of my kind of cynical advocate side. Senator Eggman is really making her political career on just releasing a plethora of bills last year, this bill, and watching the CARE, it wasn't really actually called CARE Court anymore, it's called CARE Act, that went through like 6 different revisions, and somebody else's staff had to come in and clean up her bill. So, this is kind of this habit that this individual has of, it's a very hot political football right now to be addressing. These are actually individuals, not just an issue. These are people's lives, right? And so I think, as you kind of shared, you have to kind of come out to get to the table of, like, we oppose where this is, let's work on this. The CARE Court went through, or CARE Act, as it ended up being, went through like 6 major revisions, before it actually got to be the one that got signed. So we hear things are being introduced, And like, I'm reading through 30, 40-page bills, like right? So these are very dense bills that get a lot of revision as they go. So I just kind of wanted to share that other perspective of that, so thank you.
Thank you, Elizabeth. Nancy?
I just wanted to remind our board that this board has done a lot of work on LPS reform for a long time. And I think many of us still believe in that reform. What that actually ends up looking like is certainly something we need to discuss. But I would encourage all of us to stay engaged and willing to talk about it, and particularly Director, if you could keep us apprised of what's happening at the upper levels, that's what happens. And it's gonna come down to the state and rule changing, and like Elizabeth said, someone has to take these bills to the floor and get them through all the processes that need to go through. But along the way, we can add our 2 cents for those of us, reform looks a lot different to a lot of different people. If you're a parent of someone who really needs care, it looks really different than someone if you're just kind of thinking about it. What's right or what's wrong. All that's important. So I just keep us in prayer. That's what my question or my encouragement. Also, just to keep in mind, involuntary treatment, while it is often and most always temporary. If you're in jail, you can get better and you're still in jail. Or it's not like being in a treatment center at all. So just keep that in mind. Because when to treat people, be better to treat them than have them go to jail where they then get treatment. They're involuntary hold one way or the other. If it's going to be involuntary, it'd be better to me. Thank you.
Any other questions on 43? So we'll definitely keep you informed on that one. The other big thing that I wanted to mention is what Mary Hefner mentioned earlier. Governor came out yesterday with a proposal. We're still sifting through the proposal, getting bits and pieces of information. Don't want to throw the baby out with the bathwater, as we go. We definitely need beds across the state. The biggest concerns that we have with the proposal as it stands is the sweeping out of MHSA dollars out of our system. And so the best calculation that I can do based on what we've been given so far, our total allocation for MHSA, what we're projecting for next year is 61 million. This proposal would reduce it to about 42 million, about a 30% drop. It would.
Scott, is it 61 million statewide?
For us, for Ventura County.
That's what.
Yeah. So these are local numbers. Most significant change is the elimination of the categories of MHSA funding.
Yes.
And so what would be eliminated that we fund a ton of great programs with would be prevention and early intervention, PEI. It's eliminated entirely. For Ventura County, that's about $11.5 million. It funds things like all of our suicide prevention efforts, all of our K through 12 wellness centers in schools. Many of our treatment programs are considered early intervention, like our first break psychosis program, BHAB. One step is there's a whole variety of programs like One Step Out is MyCop, Rendo, I mean, on and on and on, the list goes. And so trying to figure out other impacts, because it would also reduce our treatment dollars by about 25%. And so that's also a pretty significant number. So
The 25% treatment numbers.
for treatment dollars, yeah.
Which is 61 to what?
Well, the overall allocation,
42.
everything in total is from 61 million down to 42.7. So about $18.3 million reduction.
I did not see the press conference, and thank you, Ms. Hafner, for bringing that to our attention, and Director Gilman for giving us a little bit of information. how, where is this at? With
It was-
Governor Newsom?
It was, he and his staff, and as Mary said, others had a press conference yesterday in San Diego. And so that's where it was announced.
It was announced as
As a proposal that will go on the ballot in 24.
that's my.
Yeah. So we have a minute. We have a minute. to-
Bond?
Yeah. Bond.
Yeah.
But we have to sit through. It's not clear yet exactly how the bonds will be financed, if MHSA was being diverted for that or not. And so we'll see. The other problem I have about removing funding to pay for something that needs to be built. Now, this is what happened in California to our regional systems for the development disabled. A bunch of money was taken out of their system and people were moved out of the state hospitals to build they call them cottages or different programs all over the state. It's been several years, the state's still building them. But during this time, families had to deal with no state hospital and no alternatives. And if you have anybody that has family in that system, you know, they can let you know. So we don't know yet, you know, it's so early right now. We're still sifting through. I have another emergency call at 3:30 today that I'm going to need to go to. So we're still sifting through. We have a minute. I'll keep you updated, but this is pretty historic stuff. On one hand, we need more beds. It's great. What do those beds look like? Are these mini state hospitals? You know, are we going back in time? Are we going forward? It's a lot of good ideas in there. We don't want to say that. And the sweeping of the money would go towards housing and but how that housing is targeted and things, lots of details we have to go through. So I would say I could answer any questions on that, but that's really about all that we know at this point. Other than, all of the different programs that would be impacted, many of our providers would be severely impacted.
Go ahead, Diane.
Is this,
Then Mary
is
has-
a bond that has to be voted on, correct?
I can hear you.
5%?
I can't hear you.
I'm sorry, this is a bond that needs to be voted on?
Yes.
5%? Oh,
I don't know.
okay, I'm curious, but.
He's proposing to have a bond during the 2024 election.
That's what he said yesterday.
Mary Hapton.
Yes, hi, I appreciate all your comments, Director Gilman. I think this is something that the BHAB should get involved with and should at least contemplate and maybe bring back for discussion. I wish some of you had seen the press conference because it was an important group of people who got together. It's decision makers who are going to try to figure out how we move forward in the state of California as we are dealing with people who are living in encampments, who are chronically homeless, many of whom suffer with the most serious mental illnesses. And the overall feeling that I got from the press conference is that we finally need to help the sickest of the sick. It is really an issue, and I'm paraphrasing, of justice, of political will, and of doing the right thing. And so I hope that there's a way that that we can, move the dial on this issue. I know that is what we are all working toward. I know that's what we all care about. And I do believe that the governor and people like Mayor Steinberg and the President Pro Tem of the Senate, the supervisor in San Diego, they care about this issue. I would hate for us to just automatically say, oh, they're going to get rid of certain programs that we don't really have data on, VC Pop, on how are those affecting outcomes? Are those programs that are really, are they working to make life better for people? I don't know that we have data on some of the programs that you had raised, Scott. So, I mean, we have to look at, I think Michael was right. We need the infrastructure, right? And sometimes when there's more infrastructure in a county, the LPS requirements change. People, they know they need to be involuntarily hospitalized for a temporary period of time. That infrastructure matters. So I thought it was a very good press conference. I thought it was important. And one of the other things that they mentioned was the importance of county leadership in partnering with the state in trying to really make a difference here. And I feel like there's the political will at the state level. I hope there's a political will at our local level as the county works with various cities in the county. But this is something we should hopefully, coalesce around, and maybe we can agree on some things and maybe disagree on others. But like Scott said, this is a big deal. And to quote Gavin Newsom, he said, this is a big idea, a half a century overdue. So thank you for that time that I got to talk about that.
Thank you. That concludes your report. Any other one? I'm not trying to. I just want to make sure that I know.
Yeah, thank you. Yeah, and I agree with the comments. I think there's many babies in this bathwater that we definitely don't want to just automatically oppose. And the administration has definitely, had a commitment to making our system better. And I think since I've been here in California, I've not made a secret of we have a lot of work to do in our system. So resisting change just for the sake of resisting it, I don't think would be wise. It's just we need a little bit of a planning process here. Process.
Thank you.
Stay tuned. As soon as I get anything, I will send it out to this group as details come in.
Yeah, so this is a public meeting, so we need to be able to hear you.
Link to the press conference,
Oh,
I
okay.
could just send it to the administrator.
Sure.
Thank you, Diana.
So I wanted to ask you a couple other things in the reports. Okay. So on the Access and Outreach Division, maybe we could just get a little bit more information at some point, not necessarily today. Because, we keep hearing about access, and it seems, I know I was surprised to learn that 2 or 3 years ago that there's this whole department that goes out and does engagement with people, and we're always talking about other engagement. So, this is written, very nice kind of marketing language, but it would be nice to have a little something more concrete. And I'm kind of curious because I do look at staff, county employment page, so recruiting and onboarding new staff, I'm not sure where they're posting or what that's coming with, so that's just a question that I have. There's a thing on here about, the nurses pilot project, I'm guessing. Are they like psychiatric nurse practitioners? What exactly is their role? What's happening with that?
It's for we've never had nurses in our adolescent clinics, so it's psychiatric nurses to help really to do some of the work that the psychiatrists have to do now. They're calling meds and those types of things.
So are they prescribing, or they're kind of following up, or
They're not
psychiatric?
practitioners. We may have to look at that at some point in time.
Yeah.
Sooner than later. But at this point, this pilot project is really this for nurses to assist.
Just supporting psychiatry.
Yes.
So they're not even looking also at physical health stuff and the kind of.
Well, they would do, blood pressures and those types of things, but it's not a fully integrated program. That's not the purpose.
Right, because we know the side effects of with neuropsychosis. Okay, that's great. I'm curious because it seems like there's the same conference here with different names. Southern Counties Regional Partnership on Trauma, and then Southern California Regional Partnership. Was that the same thing, or?
Yeah.
Okay.
Well, one was for adults. Southern Partnership is our training consortium. What page are you on?
I'm sorry, 3. It looks like the same dates, but if I just wanted to look stuff up, I wasn't clear what one it was, but. And I guess, I also would like to share something, an indirect personal experience about why sometimes it's really hard for me to listen to our efforts about fentanyl. So, part of my life on like kind of a different pseudonym, I do karaoke most nights, right? And, so someone who is kind of well-known and we sing in a lot of, anyway. So this person went to buy, I'm probably guessing hallucinogenics. That it was unaware that had fentanyl in it. And so like during our last meeting, literally her organs were being harvested. Right, because she did die. They couldn't revive her. So, you know, sometimes, you know, maybe similar to family stuff, you know, we're talking policy, but like, you know, last week, somebody who was 37 years old froze to death, right? Word on the street is the person probably nodded out on fentanyl, but then had hypothermia was the official cause of death, right? So it's happening, right? Suicide every 3 or 4 days in our county, right? Death by suicide. Let me just be really clear. We've got to keep saying it's death by suicide. Death by suicide every 3 or 4 days. Fentanyl. I mean, the overdoses are much more than the people actually dying by overdose. So sometimes, you know, I feel very frustrated with some of our campaigns that I believe from my interactions with a lot of people are not really hitting people that are actually the intended recipients of the messages. You know, so when I'm coming, you know, there's a reason I'm always speaking up and pushing. You know that. I know you hear me. So it's just really, for me personally, I can only speak about my feelings, really frustrating when we have so few resources and a lot of decisions are kind of made on relationships rather than like, well, what are the people that are supposed to be hearing this or receiving these really going to respond to? Why, like, I strongly believe we really need more lived experience voices at an earlier time in making some of these decisions and programs. So that's kind of my thing on that. I'm sorry. And again, I'm really eager to hear about Colleen and kind of my last question, well, 2 questions, and thank you for being patient about this, everybody. In the training program, I know we got that grant for the mentor program, right? From the HCS had that one of the third kind of thing in their workforce development was the mentoring program that Ventura got a grant for. And it's not really addressed here. It's talking about other kind of training. So at some point, I'd like to hear how that funding's going and that project's going.
Okay.
Just
Peer training?
no, it's not. It's actually the first, there were 3 parts of it. The first 2 fundings was, you know, the for established peer organizations. The second one was for the EPIC peer organizations such as I'm Standing Up. And then the third thing they directed toward a kind of a very structured internship, but also developing mentors within the behavioral health department. So there was kind of building relationships with schools, including internships, and then building mentoring skills within staff. So that was well funded. We haven't had a QMAC meeting in quite a while, it feels like. So I'm interested to hear at some point soon, maybe a little bit more information next month about the emergency room follow-ups. I kind of, when I look at the Board of Supervisors agenda, kind of see these contracts going out, but I don't see the jobs posted. I'm not sure what's happening on reentry from the jail too. There's supposed to be like some in-reach and stuff. So these are great because this is like the most evidence-based, most cutting-edge stuff. So I'd really like to hear what's happening because we know this is the most current research for what works. Yeah, so thank you.
Liz Warren.
Thank you, Chair Rodriguez. I have a follow-up for Director Gilman. I'm curious regarding the notice of allocation of the $13.2 million for bridge housing. And you explained that you're putting together a proposal on how to utilize the funding and that it's still being developed. So I'm going to once again publicly go on record and ask you what your stakeholder process looks like and how early you're getting family members and consumers and clients into that process in terms of building out a proposal regarding the allocation of 13.2 million. I get frustrated, and this is not based toward any particular person, when things are done and then we're notified after the fact. And I think that I continually harp on the stakeholder process because that's what this is. This is what we do, you know, oversight and accountability, and we participate in giving feedback regarding program policy and expenditures, evidence-based outcomes. We want to see the best utilization of the fundings that we have. And when I see something like this, that's right now in the embryo state, I don't want to miss the opportunity of the department calling in the appropriate advocates or entities that will be able to offer a unique perspective and help to inform the ultimate proposal. So you may say to me, well, Liz, I'm definitely going to do a stakeholder process and I'm going to hold you to that. But I just really want to go on record because this is an example of where I strongly recommend that you pull in people from the community. Thanks.
Thank you, Liz. Roberta Garriga.
Hi, I just like to, Roberta Griego, Executive Director of NAMI Ventura County. I'd like to just kind of reiterate what Liz just has made the comment, Scott. You know, we're always willing to come to the table and work together to make a better process and things working. And like both Mary and Liz said, it's an organization that certainly can give you a lot of perspective from both the peer side as well as the family side. So I just wanted to make that comment. Thank you.
Thank you. Any other questions regarding the director's report? Any public comment regarding any other public comment regarding the director's report? All right, board member comments and announcements. Before we get started, I wanted to welcome our newest member. And I will invite her to introduce herself when she feels ready during this portion of the meeting. And I just wanted to welcome you and look forward to working. So, board comments or announcements.
My name is Diane McKay, and I most recently served on the community college board for the last 12 years, which is an elected position for Area 2. Prior to that, I served in K-12 in a variety of commissions, and I actually was on the Traffic and Transportation Advisory Commission of Thousand Oaks. And a kind of lifetime member of Ventura County, raised my 4 children here as well, and I'm happy to serve.
Welcome.
Thank you.
Any other board member announcements or comments? All right, we'll turn it over to you, Liz, on personal work report.
Thank you. I first want to say that Ratan Bhavnani, who is a member of the group, unfortunately had to fly to Washington, D.C. due to a death in the family and is not unable to be here today. So I'm going to be doing this solo. So I hope that I cover everything. That this is not, you know, a formal presentation. This is a report, and I want people to understand that because I know at the end of what I'm going to be talking about, we do have an ask, but because we can't do action items, I don't know whether I should do that ask or not. So maybe, Michael, you could clarify that for me, because we are going to be asking the board to do something, and I don't know if that's considered an action item or if I should leave that out. I don't know. It's in the documentation that was attached to the email, so you can all read it. But I mean, they're at the end of what I'm discussing, that's going to happen. So should I not do that, or what do you want me to do?
Liz, you can make the request, and because it wasn't an agendized action item,
Okay.
you wouldn't be able to, even if we had a quorum, we wouldn't be able to take action on it. However,
Okay.
included on next month's agenda. In case and resolve.
Okay, great. Thank you. Thank you. I appreciate that. So hopefully most of you had a chance to read through the report that was sent out with the other paperwork and documents associated with today's meeting. I think it's important when we talk about the ombudsman position is that this has been an ongoing issue for many years. And when we went back and looked at when there really started to be a discussion about this, it started in August of 2020 under previous leadership of the BHAB. And it was supposed to be discussed at the September 2020 general meeting, but got tabled due to a lack of time. And then it just kind of never really, it never really surfaced again. And so what happened then, let me just bear with me for a moment. I'm having to read my notes from a screen because where I am, and I'm in San Francisco for a family, death in the family, so I don't have a printer. So just bear with me. The issue did reappear. Hang on. I'm sorry. Bear with me for a second. It did reappear in 2021. And okay. And essentially, I'm going to summarize this because it appeared in 2021. And at that time, there was a discussion with Dr. Johnson, who was the director of the department at that time, about the position of a ombudsman / peer advocate possibility. And that was a position that she was responsive to and willing to look at, and said that she'd be happy to discuss it further. And there were some additional conversations in April of 2022. And essentially, there was I don't know how to say this. There was I want to say maybe promise from the department that they would take this request from the BHAB seriously, look at it, look at funding, and incorporate it in the request they were going to send out to the Board of Supervisors for additional staff. And I believe at that time there was a discussion of the so anyway, I'm sorry, I'm a little flustered because Rattan has some of this, so I'm trying to make sure that I get everything here. So essentially, I think what's important to understand is that, and I gave you some of that information at the top of the documentation, some context, because a lot of you were asking, well, what in the world is an ombudsman? And I explained, and I'm just going to read a little bit of this. It's an independent, unbiased individual that provides cost-free services. They investigate complaints when problems have been inappropriately managed or individuals undergo unfair consequences. And some of that can be maladministration and inconsistency and delay and negligence, and a bias and disrespecting presenting inadequate suggestions. And so in doing our research, we found that there are many types of ombudsmen, and we looked at them. There's primarily 7 of them, and they're listed there on the first page. But we took a look at 2 possibilities that we wanted you all to see, which was the organizational ombudsman and the advocate ombudsman, and the descriptions are there. And they're pretty self-explanatory. I mean, so I would recommend that you read that. I'm trying not to get in the weeds too much because I want to make some additional emphasis on certain things, but I want you to take a look at the California Department of Healthcare Services information that I included in the documentation. The Medi-Cal Managed Care and Mental Health Office of the Ombudsman exists at the state level, and because it's a Medi-Cal Managed Care and Mental Health Office of the Ombudsman, it helps solve problems from a neutral standpoint to ensure that our members receive all medically necessary covered services for which plans are contractually responsible. And the ombudsman is designed to create a bridge between the mental health plan system and individuals, family members, and friends of individuals in need of mental health services by providing information and assistance in navigating through the system. The ombudsman will not automatically take sides in a complaint. They consider all sides in an impartial and objective way, and it's their job to help develop fair solutions to healthcare access problems. So what we did, meaning Ratan and I, we took a look at what we would envision the mission to be for what we're right now calling, it's a working name, the Ventura County Behavioral Health Ombudsman, VCBHO. And we see the County Behavioral Health Ombudsman is designated neutral and works independently as an intermediary to assist any individual that interacts with Ventura County Behavioral Health with exploring and determining options to resolve conflicts, problematic issues, or concerns. The VCBHO provides a confidential avenue to address complaints and resolve issues at the lowest possible level. They propose policy and procedural changes when systemic issues are identified. The VCBHO's primary objective is to advocate for a fair process and fair administration of services. And then I list some of the advantages and disadvantages, which I think are probably innately understood. But one of the things that people forget is that this would be a cost-free service. And I think there's a tremendous benefit to that, given the economic strata that we have of clients and families that are receiving services. And also that it's an autonomous system. It's independent from the institution, the individual, and organization. And they create a record, they create a paper trail. So they're reporting while methodically addressing issues emerging under a county agency or while deploying a county program or service. There are some disadvantages, and ombudsman is unable to render instantaneous solutions for very complicated problems. And the individual with the complaint has no sway on the investigation. An ombudsman does not advocate for the individual or the county agency or organization. So I think it's important to remember that none of this, if an individual, family member, CBO, contractor, whatever, was going through this process, you know, it's not a slam dunk. It's something that has to be looked at within the context of the complaint and then have some kind of resolution. We identified the role of what we envisioned, and you'll see the word draft at the top of page 5, because we know that we would like we would like additional input on what this individual could actually do. And so we lay out the fact that they would respond to inquiries from a variety of agencies and individuals. They may be contacted by a consumer, a family member, a community member, or staff from an agency. They listen, answer questions, analyze the, I'm sorry, hang on a second. Situation and the context of any complaint or issue, which is very important. They review the application of Ventura County behavioral health policies and procedures and advocate for the fairness of a process as opposed to advocating for an individual party. They provide information at times, advice, and develop options, suggestions, appropriate referrals, and recommends a possible resolution. The VCBH ombudsman apprises the healthcare agency in Ventura County Behavioral Health of significant trends and may recommend changes in policies and procedures. The VCBHO does not disclose and may not be required to disclose information provided in confidence, except to address an imminent risk of self-harm to an individual or others where there is no other responsible option. The VCBHO may disclose information relevant to the complaint when in possession of a signed release form and consent from the individual. So we wanted you all to be aware of that. I I think when this was all being discussed with the department, there was some kind of miscommunication based perhaps on the language that was used, semantics that were used, the context that may or may not be understood when it came to what the BHAB was actually asking the department to do. And somewhere along the line, the ombudsman became a health navigator position. And when Director Johnson went in front of the Board of Supervisors and requested 50+ positions, it was like a health navigator position, and it wasn't the separate ombudsman position that we had requested. And I know currently that Director Gilman is looking, and his staff is looking to hire what they're calling a behavioral health patient navigator administrator. And I would just recommend they call it a behavioral health client navigator. We haven't used the term patient. I've been in the department for over 22 years, so that might want to be changed. And what they're saying there is that would be an administrator position that might have one level of subordinate to help them. So they're really looking potentially at 2 positions. And there's only one sentence above and beyond helping individuals navigate the services and essentially link them to services. So in my mind, it looks like just like a little bit more high-level case management. But they do indicate they want somebody with good judgment and diplomacy and understanding of the system. And then there's just this one sentence: resolve service challenges from a neutral standpoint. Well, an ombudsman does more than that. An ombudsman takes a look at the whole fair distribution of access, and access can vary depending upon what group you're in, what minority, underserved community you're in, where you are in the county, and who you may have as a case manager, whether you have a case manager, whether you're in therapy or not in therapy. And so it depends on the individual consumer's support group that's around them that can affect the level of service that they get. And what happens often is clients and family members get very frustrated because a problem will arise, a conflict will arise, a misunderstanding will arise, and it just continues to snowball without any real resolution, because there seems to be a pushback from the department, a resistance from the department about looking at things with total transparency. And I believe, and I think it's important, I'm going to acknowledge this publicly, that I think the department takes a defensive mode rather than looking to be proactive. They're reactive and defensive when someone comes to them from the community and says, this is what we're experiencing, and we're frustrated because it's been going on for a long time, and we're not getting a resolution that we feel is effective for our loved one or for ourselves. And I would just say and encourage the department to look more at the whole process as collaborative. Like, okay, we've got this issue, let's solve it together, and let's look what's out there. And if the ombudsman is identifying, oh, this is happening in multiple places, there's a systemic issue here, then they go to the department and say, part of why this is happening is because of what's happening in this clinic, or what's happening in this program, or what this particular provider is or is not doing. And I think that's part of the big overall difference is you not only want to have resolution, but you don't want to keep reinventing the wheel. So you want to be able to implement change and fine tune on an ongoing basis, fair access to services. Under MHSA, the Behavioral Health Advisory Board, that, we're chartered with oversight and accountability. And we have to help individuals in our community that don't have a voice, and they don't have a voice on equal footing, to get the help and resolution of problems that come up. I mean, that's part of what we do. And many of us feel that an ombudsman position that would have independence and be able to look at the larger context of what is happening is an appropriate position for the department. And I think that people will say, well, we have a grievance process, and we do. And I add there's a page about our grievance process, and the grievance process is essentially a phone line that's manned by 2 clinicians like LCSWs who check the voicemail a couple of times during the day. They get the individual's complaint. The complaint can also come in written form, and then they have to respond within 5 days if they've received their grievance, and then they start the process. It has to be reported up to the state, and they have 90 days to find a resolution. And I'm typically not a very cynical person, but I'm going to go out on a limb here and say that I feel like sometimes the department doesn't want to utilize the process to the extent that they're required to, because suddenly at the state level, someone's like, well, what's happening in Ventura County? Why are we getting all these grievances? And I think what we want to do is maybe take a little dive into that. And I know from working with quality improvement, because that's where the grievance process sits. It sits under their umbrella, that they're doing a lot of work and trying to get this more fine-tuned, and they've come up with a new grievance form, and they're trying to make it more user-friendly. But I still think before a family member or a client gets to the official reporting to the state through the grievance process, as we say here, the ombudsman's at the lowest level. So we're not trying to throw grenades. We're not trying to set things on fire and blow the system up. We're trying to actively participate in a collaboration between the entity and the department, and finding a solution and the level of care and problem solving that we think the individual in question needs. And so after looking at all of this, we feel that there is money available, especially based on they just posted the behavioral health patient navigator, and they did 3 levels, administrator 1, 2, and 3, and the salary range is $66,934 to $109,897. And so I know, just in conversations with Director Gilman, and he's been very transparent about it, that he feels that if something has come up, there is a way to find funding. And that's something that we can discuss, like where would this come from, and ultimately where would this position sit. And I think that's something that if the board wants to pursue this, we could take a look at it. But in conclusion, we are essentially asking the board, let me just make sure I get this correct. Hang on one second. So in conclusion, the Ombudsman Work Group recommends the Behavioral Health Advisory Board move forward once again and request Ventura County Behavioral Health to create the position of an independent ombudsman. If the issue complaint cannot be resolved by the VCBHO, then the ombudsman refers the individual or agency staff to Ventura County Behavioral Health to file a formal complaint and begin the formal state regulated reporting process, which would be the grievance process. So I hope I've adequately articulated those of us that are in support of this position. And if there are other people here, because I know that there are folks from NAMI that are very much in favor of this, please feel free to jump in and add if I've left something out. And if you have any questions, I'd be happy to answer them. And if I can't, I will get the answer for you at the next, our next opportunity. So thank you.
Thank you, Liz. Other questions, Flavia?
Thank you, Liz, for all your work on this. I think this is a really important position, so I thank you and your group for their work. I have 2 questions, one for the director, and the second one, I think maybe Liz or Roberta might best be able to respond. But given how complex the system is and challenging for families and consumers to navigate, I know that NAMI does a lot to try to support families and direct them and help them troubleshoot. But my question to the director is, would this type of position have more direct access to county staff to try to resolve issues? than an outside nonprofit, for example, and will they have more leverage?
That's a good question. Before I answer it, let me just say, I feel like we're getting too close to the fire on the Brown Act, that we're kind of deliberating over a recommendation. So I think it's okay to go on, but we have almost a recommendation, and now we're gonna start to deliberate whether we support it or not, or what does it mean?
Well, I'm going to, Director Gilman, I want to interject. The request was made, but nobody has to comment on the request. So I think that was the point that Michael was saying earlier, so that we don't violate the Brown Act, because it's not an action item. But I think that Q&A might be appropriate, and if it's crossing the line, then that's fine, whatever is determined. But I think some just quick Q&A would be appropriate, but if I'm mistaken, please feel to correct me.
I'm not an attorney on this one either, Liz, so to me, it just felt like we're getting a little close to the fire. My gut's just telling me.
Okay, and I'm comfortable with that. If people don't want to continue the discussion, perhaps we can pick it up at the next meeting. But I think if people like Roberta would like to go on record and make a comment, I think that would be okay, but that's just my opinion.
I'm gonna, and I could be wrong, but I think we can continue the conversation. In one part, we don't have a forum here, so that we're not, the Brown Act is triggered when we have a majority of a committee or the board discussing board business. Since we don't have a forum, and we're also doing it not in public too, although it's not a formal meeting, I believe we can still inquire and make inquiries and ask questions and have a discussion on it. We just can't move forward with any kind of action item. And it wasn't agendized as an action item either way. So I believe we're fine. So I'm gonna allow questions or comments regarding that. Liz Stone was next, followed by Roberta. Or Elizabeth Stone.
Well, I think a question was asked of Director Gilman, and I think before he answered it, he just questioned where we were in terms of violation of the Brown Act or crossing the line. So maybe Director Gilman could go back to that question.
So I think to answer your question, there's lots of organizations, well, not lots, organizations like NAMI, programs, peer navigator programs that all, could do this sort of work. The question is, how much additional privilege will this individual have? We always operate on a need to know, even if somebody's, internal. And so how they would interact with the formal system depends on, what's happening, if, depending on if it's going to be a Medicaid or Medi-Cal, I'm sorry, fair hearing process that they refer to. There's one set of criteria. It just depends on how serious the situation is and isn't. And if consumers going to they're going to have to sign releases of information for them to talk to the clinical staff to allow that. So
Right.
It's I do like the idea of it being attached somehow or working with our data people, our quality people, because we want to look at, and we do look at all of the incidents that come through and trends and, what corrective action can we take based on how many accidents that happen, that sort of stuff. So that happens. I don't think it would be reasonable to ask this person to go in and pull all of that data, and be on the street as well. So
Well, yeah, I'm sorry, I don't mean to interrupt, but the quality improvement team already, the grievance process is what falls under their umbrella. So this would be TBD down the road to figure out where this position would sit. One of the things that I just want to clarify, the ombudsman would have access based on what I presented and what I've researched to administration. They would be creating a channel, confidential channel, to help facilitate a conversation with administration, which might mean a division chief or somebody along those lines. And so I think that if a client signs off on confidentiality and the sharing of information, I think that would be just in my assessment, just part of the extension of the process. So I just wanted to clarify that. Thank you.
My second question was to anybody who would have insight, given the number of behavioral health clients in the system, how many staff people would this office need in order to provide prompt service?
Well, right now, I don't think anybody can answer that. I know right now the department is looking for this behavioral health patient navigator administrator, and they've got the administrator position. And then under the position, they have responsible for one level subordinate supervising position. So they're already looking at 2 just for their navigator. I would assume that, you know, a couple. And I also think that we definitely have to have a bilingual ombudsman. And so, you know, you could have 2 and one could be bilingual if necessary, or both can be bilingual. But, you know, all of that fine detail will be worked out down the road. This is something that the board wants to continue to pursue.
Thank you.
Roberta's had her hand up. I don't know. We can't see the room.
Elizabeth, I got Elizabeth Stone had her hand up before.
Okay. Okay.
Also, board members go first, right, Liz? So, my comments are not directed at any individual. This is a policy and procedure comment mostly. And this has been a point of frustration for me personally for many, many years, either as like sitting as an official member or outside having to make public comment. For me, this is another, and I really hate when people put a lot of work into something like this. This is starting with what you want and then building a justification for it, rather than as a policy saying, this is a need, what's the best solution, right? So, I see there's a lot of work here, but for me personally, this is not really a policy proposal or an action proposal, because it's not saying, this is the problem, this is the need that we're not meeting. What I have heard, and I've mentioned it every time it's come up, is that family members aren't getting the department to do what they would like and they believe is best for the people in their family that they believe need care. And so this is something that historically has been around. So people are kind of saying, let's try this thing again because we've done this before. And so of course, my concern is always build the family relationship. And this is where I think NAMI can really step up and help families have really good communication, have that, you know, we have a law in place that anyone over 18 can decide to or not to sign a release so their family members can be active participants and knowing what's happening with their treatment. And you know, there's that legal boundary there that you know, is challenging actually for both sides. You know, I know, and I'll just share my personal experience when I was in the hospital and actually letting my mother come to visit because I was really hopeful that maybe this time it would feel like I was loved, was actually much, much more painful for me because it didn't go well, right? So even though I was open to things, and I'm just saying, I'm just sharing my personal experience, even though I know that this is something shared by many, many people. We kind of know best intentions do not always end up with outcomes that feel like the best outcomes we would all like. So, you know, part of, again, my concern is I'm not sure which problem or which gap or which need this is actually trying to address. If in fact, I mean, you did kind of add consumers every time after you said family, So I'm not really sure exactly what the problem that you're trying to address is, what other options you've looked at. I have mentioned, and I have the information this time, there is ombudsmanventura.org. There is an ombudsman organization in Ventura. So for me personally, before I could support anything like this, I would like to know exactly what the outcome is, or why you're proposing this really clearly. I'd like to know what options were evaluated and how you came to, or how one committee came to decide that this is the best option. It would be helpful for me also because, again, this is something that I've noticed in the 8 or 9 years I've been participating either at the table or as a public member. I don't know who was in the work group. There's no names. I don't know if it was just you and Rich. I don't know who was in it, when you met. That would kind of be helpful with a policy document. These are the members of the work group. These are the times we met. Again, something that kind of directs us as a policy action rather than like, this is something we'd like, so we built this argument for this. So that's kind of how it feels to me. I've mentioned this every single time it's come up. And I do see that it was in the minutes, but it wasn't one of the highlighted comments. So I'm just, that's just continues to be my concern. We have very little resources. Great, we're going to find things when we need them, but let's just be really clear. What are we trying to do? How are we going to measure it's successful? You don't know if you don't know what you're trying to achieve. You don't know why this is the best solution for what you're trying to achieve. So those are my concerns. And again, it's not meant to anybody personally. I am bringing in my personal experience because I want to be clear about how my perspective is colored by my own life. So not that that's unique or anything, but it's kind of this one.
Well, thanks, Elizabeth. I appreciate your input and your feedback. I started by saying this was not, this was a report. This is not a policy paper. This is not a proposal for, like this completely dialed in program or position. This is the context for what an ombudsman can do and cannot do. What we had kept hearing, those of us that were interested in this position, is what's an ombudsman? What's an ombudsman? So I'm essentially reporting back and telling you that we took a look at it, and this is what an ombudsman is. They exist at the state level in the Department of Health Services. They exist at the county level, and now we're looking to have one exist at the departmental level. Yes, you're correct. There are ombudsmen throughout the county, and typically ombudsmen are attached to long-term care. There is a very robust ombudsman position for folks that are in SNFs, and there are many of them in the county. So I don't want anyone to think this is like a final product of the work group or a fait accompli, or that's how we're presenting this. We're very open to looking at fine-tuning and pinpointing additional things if this is what the board wants to do. And I think that I'm just going to say flat out, when we met is irrelevant. And the members of the board, of the work group, were me and Rattan and Jennifer Morrison. Jennifer had to step away because of a death in the family. And Rattan and I were the ones that moved forward with taking a deep dive on this. Michael Rodriguez asked people to join the work group, and the three of us were the ones that expressed an interest. So what you're getting is the results of what Rattan and I worked on, and it's being presented as a report. Thank you.
I get that, but there is an ask. So you're asking.
Well, and the ask is based on, hey, this is what we found out, and we are asking to revisit for the BHAB to revisit what we originally did in 2020. We started in 2020, and then we did in 2021 with a letter that went to Director Johnson. And then because of COVID and a variety of things, it just kind of got lost until she went to the Board of Supervisors and requested those 50+ positions, and then came back and said, we've got a health navigator, not an ombudsman. And then that's when there was a bit of a surprise to all of us about how that got turned into a health navigator. Now we're back here in 2023, new administration, and they're advertising and wanting to hire a behavioral health patient navigator administrator. So I feel like what I'm asking is, and maybe the ask and the way that I worded it isn't as accurate or on target, but I guess we're asking, the work group is asking for the board to reconsider this, and then if we want to move forward, well, then we can ask again, can we ask the department? Like, if this is the first step of let's get this back on the radar, then, you know, if you then I'm happy with pulling back that ask of asking for another position if that turns people off. But I think the goal here was to look at it and then to come back with the information that we reviewed. So
I hear that, and I'm just asking, I'm asking for additional information.
Too far.
That's all.
Okay, let's move on. We have one more public comment or question from Roberta Grego, and we'll move on. Thank you.
Thank you, Michael. First of all, I want to say that my long history of working in the clerk of the board's office for over 39 and a half years, I think it's time that you might want to put it to a halt and certainly it is kind of getting out of the realm of the report side. Her question is definitely, will the board consider, I think, bringing it back on your next month's agenda? That way Rattan will be back in town. He was part of the committee. I will say that Rattan is also part of the NAMI advocacy group for NAMI Ventura County. So there was like a representation from our group. So, but I agree that I think, you know, unfortunately, you might want to check with county council, because your board members that were absent to be able to vote, if they vote for this next time, probably will have to go back and listen to the tapes from this conversation. So that's all I'm saying at this time. But I would have comments certainly if this when this comes back, I hope next month to the board.
thanks, Roberta.
Thank you, Liz. Mr. Chairman.
I just wanted to say thank you to Liz for the report and for the work group also, and to Rattan, who is absent today. So it was a lot of hard work and it's a very thorough report. So whatever we end up doing, but I just want to say thank you.
Thanks.
I'd like to turn it over to Dr. John Schiffer and Gary Carson, presentation on full service partnership.
All right, well, thanks for having us, and we've been asked to prepare a presentation on FSB's kind of an introductory in light of the fact that there are a number of new members and likely some questions and lack of understanding about full service partnerships. So just by way of introduction, I'm John Schiffer. I'm the adult division chief for Ventura County Behavioral Health. MHSA funding and the MHSA staff are currently under the adult division. Introduce yourself.
My name is Hillary, and I work underneath the MHSA department.
Selling yourself short. Hillary is a program administrator. I mean, it's longstanding, one of our best local experts on MHSA. So with that in mind, there's a PowerPoint on the screen. How fortuitous. Hillary's we're gonna trade off on some of these slides. We, in light of the fact it was said to be 20 minutes, we've got just an actual 10 slides. So we're going to trade back and forth a little bit and have to entertain questions, but if you just let us get through the presentation, I think that'll probably work out best.
So you can go to the next slide. Okay, so FSB is one component of the MHSA. These are some of the overarching requirements of an FSB. It falls underneath the Mental Health Services Act. There's specified target populations for all of these programs and these service types. This is kind of the ballpark to give you an idea of the MHSA money that comes down, what percentage overall is supposed to be going to full service partnerships. The services and the target populations and the data requirements are all specified by the Act itself. And so FSPs are programs defined by state regulations that provide like a full spectrum of services, both clinical and non-clinical. And we are required to have a robust community planning process, which for this next 3-year plan, we're just starting to pull down. That's it for that slide. Go to the next one, which is kind of what FSP regulations were based off of, which is the ACT model, assertive community treatment. Been around since the 1960s. It was out of Madison, Wisconsin. And the idea is to address the revolving door of client discharge and readmission clinics developed ACT as an intensive outpatient program. So it's an evidence-based practice, and we are moving more towards an ACT-like system of care here in Ventura County. And it is, there are specific requirements around ACT, and some of our programs follow ACT to fidelity, while others are going to be following different elements of ACT that we're trying to strive for. I think that's it. It's very expensive, but it's also highly correlated with positive outcomes, including decreased hospitalization, greater housing stability, better quality of life functioning, and retention and treatment.
The way I think about the relationship, one of the questions has been, so what's the difference between FSP and ACT and other things? The way I think of this, ACT is a tool that gets utilized in a multitude of settings, lots of different programs, one of which is FSPs. It also happens, I just wanted to see this, that I guess an awareness of ACT was at play in the development of FSPs, so it did have sort of an informative sort of role when it came to developing FSPs. But generally speaking, ACT is not exclusive to FSPs, and it's like Roby said, it's an evidence-based approach, which is you see in lots of places for many years. So folks who've been around a while have seen various sort of pyramids that an attempt to sort of relate our continuum of care. Here's one more. I tend to have issues with all of them, but setting that aside for a second, the part that's really sort of important here, the goal of this slide is to essentially speak to the fact that really FSPs are at play in our outpatient services. And within our outpatient services, there are roughly, think of sort of 2 levels of care. So there's the regular or typical outpatient services that get rendered in the various physical plant clinics and programs. And those tend to be less intensive by virtue mostly of staffing. Something also to do with resources. And then the FSPs, which tend to be more intensive in terms of staffing, a little bit better access to resources. And as Hillary was saying, we'll talk about a little bit more. Within outpatients, there are some programs that are in and of themselves exclusively FSP. So older adults is an example of an FSP program. Whereas in a Ventura clinic, you're going to have a combination of non-FSP clients and FSP clients. So it's in that sense, in outpatient, you see kind of a combination of FSP.
Okay, so who is a good fit for FSP, right? Who are we targeting here? We have programs that exist for all age groups, and those age groups are defined by the Mental Health Services Act. So 0 to 15 is our children and youth. 16 to 25 is our TAG, for our transitional age youth. Our adult ages are 18 to 59. and our older adults is over 60. And so we're focusing on individuals who are, for youth, experiencing risk of removal from the home, school failure, or aging out of the child welfare system. There's some exclusive eligibility elements for those age groups. For older adults, they'll also need to be experiencing a reduction in personal or community functioning. And so it's a good fit for anybody who's who needs the highest level of intensity services while still being in an outpatient type of.
So then I think one of the explicit requests was exactly which of the programs are FSP programs. And so this is an attempt to supply that information. I read for yourself, but just to highlight a couple here. Being the adult division chief, I'm not in the best position to speak to the FSP that's launching in the youth and family or insights. Although I will say there was a brief period of time where I did oversee one of the juvenile court-based programs that was the precursor of insights. Again, both tend to be similar from the adult programs we're going to talk about, where the essentially the caseloads or the intensity of services is distinctly different from what's usually at play in the rest of the system. And then in terms of age, the next one on that list, transitional age youth, for us, that typically means people who are in the age of 18 up to their 26th birthday. And again, there's some distinct characteristics about that group. One of the goals for that FSP is ideally to be able to support people in a way that steers them towards independence and dare I say, liberation, so to speak, from county services. Ideally, when and where we can, we'd like to support these young folks in getting work, continuing their education, and those kinds of things. EPICS is our adult system, it's our intensive adult system program, both both EPICS and older adults. We have more so than any other place have preserved something of a cap. I'm hesitant to say that word, but we've been mindful of staffing. We've been mindful of the fact that if you allow people in without being mindful of the amount of staff you have to attend to their needs, you can dilute the whole program in a way that becomes meaningless. And so, and at the county and the regular clinic system, basically we take all comers and we're expected to basically manage with the existing resources, despite whatever number of folks we may be in service to. By contrast, that EPICS older adults, we tend to hold the number and as a result, make decisions and that allow the highest, most neediest folks to be in those services to try and preserve that ratio that tends to try to be 15 to 20 to 1. So that's 15 or 20 clients to one staff person. Assisted outpatient treatment. So that some people know that as Laura's Law. We have an assist program. That's an FSP program for us. The only one on here, the next one is a contracted program, telecare. So telecare provides, again, something that's akin to like EPICS, so intensive adult services, with the focus being on referrals coming out of jail. So we have a county staff person that basically is our liaison in jail, and with the WellPath, the provider in jail, attempts to identify folks who aren't connected to services, who are open to being connected to services, and when and where it makes sense, if they haven't had a long history of services with BCBH, telecare often gets those referrals and then proceeds to try and engage folks. And the tricky part there is people are of a mind and suggest they're willing and open to things maybe while they're in jail, but sometimes when they get out of jail, then sometimes that motivation kind of whips away. So there's a real challenge to engage people once in the community there. And then our adult clinic-based FSP, that has actually been long-standing without, for my taste, without enough kind of consideration and design around that program. Again, it's what's typically been the case is that for the average person working in an adult clinic where the caseloads are on average around in the 60s, it wasn't uncommon for somebody with a caseload of 60 to have maybe 2 or 3 people who are in the clinic FSP, along with all the other people on the case. Well, you can imagine, it's hard to show that kind of differential sort of intensive services to that small group of folks when you have this broader responsibility. So that's why we're in the process of redeveloping with a hybrid team that will essentially pull those, at least the case management and rehabilitation services for those clinic-based people to a special team. We continue to see the psychiatrists and the nurse at the clinic, but the caseload correction that occurs with this hybrid, and again, we're striving 15 to 20 clients per staff person there. Then older adults, the focus on old, we obviously treat lots of folks who, in terms of pure age, would be over 60 in the various clinics. What distinguishes the people in the older adults FSP is they tend to have more significant, more dominant sort of medical needs. Oftentimes, a lot of times those manifest with difficulty in getting to clinic, getting either clinic appointments, doctor appointments, transportation issues. So again, intensive case management sort of needs. And that's what our older adult program folks are. And by the way, Peter Schreider, who's the CA of older adults, happens to be sitting right here. So there he is. So that's a very quick review of the current FSPs.
Okay, and so how some of the updates, I guess, what I have before you guys a couple different times in the last few years to get innovation projects approved that happen to focus on these populations. And one of the ones that we're now in sort of the implementation phase is the cross-county FSP multi-county innovation project. And that included some goals that were across all 6 counties. And that includes standardizing definitions of FSP populations. So if we define somebody as justice involved or at risk of justice involved, that can look night and day here in Ventura versus in Fresno or in Siskiyou or any of these other counties. So we got together as a team and painstakingly went through each one of those to define what that looks like so that it's the same. This is not the same as program eligibility. It is just like, what does that look like? What does homeless mean in Ventura County? What does at risk of homeless mean? How many citations? How many, have you been involved in court? Have you not? What are the elements that make that up? The second one was identifying key outcomes. So what does success look at? And we had to modify some of the state systems for reporting, as well as some of the questions that get asked. One of the places where ACT has been successful and FSPs is social interaction improvements, and we don't track that anywhere. So that was one of the things that we agreed to start tracking in this coalition. And the last one was to make some recommending changes on the FSP data collection and data collection forms. And I'll get into more detail on that later. So then we also had Ventura County focused projects, which we just heard about the adult FSP carve out. That was a result of that. So we clarified the eligibility for the programs. We clarified for FSP programs. We developed guidelines for the services. So there's a certain baseline of services that are required for any of our FSPs, even if the various FSP programs look slightly different. So there's like a minimum standard for all of our FSPs. And then the 2 new programs, the youth and the carve out for adults. And then we also defined a process for step down. We didn't have a lot of people graduating, so we're focused on how to define that and give guidance for people who know when to step somebody down. Even the next slide.
Next one is mindful of time, what I expect are going to be questions. So I think to this slide, you know, how to distinguish FSP services from regular clinic services. Like I said, it largely comes down around those client to staff ratios. That makes all the difference in the world. You might imagine, you know, being the subject of someone's attention when they have 19 other people they're concerned about, as opposed to, you know, 40 other people, or in some instances, 60 is the average. We have some case managers that have caseloads up at 100. So again, that ratio really, to a large degree, informs the difference in treatment. I will say, just because it's been a point of discussion and struggle for many years is ready availability of crisis supports 24/7. In a high fidelity FSP model, a person who is in an FSP will have access to somebody who's part of their treatment team after hours, weekends, evenings, and for a number of reasons, as a county, we struggle with that. One of which is very purely is compensation. So we have the civil service employer or unions trying to put in place the mechanisms that allow us to pay staff to be on call and available after hours is way more complicated than you want to hear. It's a tedious, boring affair. There's different types of staff. So we have hourly staff, we have salaried staff. The significance between those two is huge. It's been a huge burden for us to get over to make the staff who are again, directly involved in care, accessible to them 24/7. So our compromise fallback position has been, we're fortunate in the sense that as a county, we have a 24/7 local crisis team. So that has been essentially the resource that's available to FSP staff. Now, it doesn't ensure that they'll talk to somebody who's familiar with the case. It does ensure they can talk to somebody who has access to the record. And but that's just work of this list. There aren't a lot of things here that really distinguish. A lot of our regular clinic-based services are field-based. All of our services are multidisciplinary. So anyway, that without belaboring that much longer. I'm just talking about state mandated reporting.
Yeah. So again, we don't get to pick what we track and we don't get to pick how often it gets collected or how it gets inputted. So these are all from the state. We're required. Oh, sorry, next slide. There we go. So these are the 3 different main mechanisms for how this information is collected. The first one being a partnership assessment form or a PAP. And we collect all the domains there. This becomes the baseline for anybody who's entering an FSP that gets compared over time. The second one is a key event tracking form, which is any kind of significant life-changing, life circumstance change or an emergency intervention. So this could be that when they become homeless, when they get arrested, or it could be something like they get a job or they graduate from school. The final one there is the 3-month assessment, which is different domains than the get. And those get done every 3 months. We'll go into the limitations.
And here partner is the service recipient.
Yes, that's also state regulated. FSP participants are called partners.
So, next slide. The knowing the interest in the data and the outcomes, we wanted to be sure to sort of speak to those. Like what you've begun to hear from Hillary, there's real challenges, and this is not limited to Ventura County, this is statewide. So there has been, honestly, I would say, reasonable questions about, are these programs effective? How can you demonstrate their effectiveness? And to be honest with you, the mechanisms like we just covered for collecting that data, very cumbersome, very last millennium, very ultimately doesn't lend itself to great data. So despite what I just, I'm going to talk about a little data, but again, the data around FSPs, and again, we'll talk about why that is in a little bit more detail, should be taken with a grain of salt. So the 3 areas that are generally considered to be of great interest and understandably so is homelessness, jail days, and hospital days. And the 3 are obviously different, sharing some aspects, some qualities, and different in other ones. Arrests. So looking at some of the FSP data that we can glean from this approach is the indication that there were both a decrease in the total number of arrests and the number of participants or what they're calling partners having been arrested. So again, an indication that FSP is hopefully having something of the desired effect. Housing, homelessness, it's a much more difficult metric to try and track. The definitions of homelessness, oh my gosh, started depending on who you talk to, everybody's got a different definition of homelessness. It's very, very difficult. In this regard, the reason why it's an orange versus the green is suggestive of the two green, a little bit more positive, orange, a little bit less, but is that, the data seems to suggest that actually, we haven't seen benefits in housing. And the frustration here on our part, I can say, certainly on the provider part, is that we know anecdotally, at the very least, that you get better results when you have more manageable caseloads. Nothing else with MSP, you have a much more manageable case. So it's a little frustrating to not be able to demonstrate that in a way that we'd like to be able to do, but again, hampered to a large degree by kind of the data and methodology. Hospitalization, that's one that, again, some of you have already heard me talk about this. To me, it's distinguishable from the other two. Never good for a person to be homeless, never good for a person to be in jail. Sometimes people need to be in the hospital. Sometimes it's a perfectly appropriate response to a decompensation or a manifestation of symptoms, and you wouldn't want them to be anywhere else. That said, I get in the general sense, it's not an unreasonable expectation in the aggregate for effective outpatient services to be able to hopefully mitigate the amount of time people need to spend in the hospital. But it's a much more equivocal measure. And keeping with the equivocal spirit, we see that although the number of hospitalizations decreased, the number of hospital days increased. And we could probably debate that all day. I can tell you locally, from an operational perspective, extended stays in our psychiatric hospital have way more, I would almost say exclusively, to do with securing the right placement for somebody who needs to step down into the hospital, as opposed to symptoms driving the need for extended stays. So it's getting the next step, the disposition, the discharge in line that usually, unfortunately, dictates extended stays. So again, this data is to be taken with that consideration. And then next slide, kind of generally speaking, we're going to speak a little bit to sort of the real logistical sort of challenges of FSP data.
So as I said before, the path is kind of considered the baseline. It's a document that goes through 7 different domains, in which each of those domains, your treatment team provider is going to ask you how many days you were in a residence and how many times. So to have to remember, I myself made a move last year. If I had to tell anybody, even now, how many days I spent my last residence versus this residence 365 days ago, I mean, I would guarantee it'd probably be wrong. And yet that's what I would be measured against for the next 2, 3, 4, 5 years of treatment. So it's not a great place to start, especially when you recognize that people coming into an FSP are sick and they're not feeling great. And here we are asking a really detailed number of nights you spend on the streets potentially in the last year. So it's not a great place to start. It can be overwhelming for people. I'd say that if you're bringing them in to try to get that information on day one, and they're not considered enrolled until that path has been completed and uploaded into the DCR. DCR is the state system. It is, I feel like everybody would agree that it's antiquated. And we did, one of the results of that innovation project was that we wrote a memo to the state, to DHCS, outlining some of the difficulties with their DCR, with the data collection methods. And they wrote us a response. And so that is out there on the internet if you'd like to find it. Did not make a lot of progress, but they did acknowledge some of the difficulties that we had. It's also why there was a transparency tool that was uploaded for a few short weeks on the MHSOAC website, and then that got taken down. Just the difficulty of the data was not beneficial to anybody at this point in time. The other thing is a CAT is required in the moment. So for example, if we have a youth that gets arrested several times in a week, that requires several different CATs to be done within that week for it to be counted. So that puts a lot of pressure on our staff, and there's no changing the stakes in the DCR. So the error reports come back to us, that whole entry has to be redone, the whole client entry has to be redone. before it can be uploaded and corrected back to the state, and any future instances or entries from that point on are held until that first correction gets. It's pretty problematic.
And it's based on the assumption that, A, we know they were arrested, and or B, when we asked them, they told us that they were arrested. Right, so self-report data.
Yeah, it's also different. And so one of the things I just would like to remind you again is one of the innovation projects that we came to you for about 2 years ago was the FSP data exchange. And that is a system that is leveraging our partnerships with the sheriff's office, with the continuum of care, with our home services, HMIS, and with our hospitals. And so that data will now, we will have validated or reported some of these outcomes, which is not unlike other counties, which have built their own systems to try to demonstrate the effect that these high intensity programs are having without having to rely on the state required data. So we'll now be able to kind of do both. In hopes that the state maybe makes some changes moving forward. So that is our FSP data exchange. It's the care manager application, and it is just about complete. We're scheduled to be complete in April. And so those will be live key events, as well as it'll give our providers time to enter that information. It won't have to be right in the moment. They'll have the history that has the dates, that has the times, that has all the information they need to be inputting that data. And then we've also embarked on a process of cleaning the DCR data as it exists now. So QI, MHSA, and the training department have put several significant efforts in, and we continue.
All right. Any questions? Happy to try and answer them.
Get a copy of the PowerPoint to Jackie to distribute to. I think we will be doing the minutes that we sent out the next. Sure, when we get Elizabeth, and then followed by you.
Hi, thanks. You guys really hit a lot of my questions. Thank you. That was really, really, really helpful. Thank you. So I have like 3 or 4 kind of key questions. So in the ACT model, there's multidisciplines, right? There's like an employment, supported education, blah, 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 right? It's a peer support person. Are the FSPs functioning in that multidisciplinary manner?
All the treatment teams are multidisciplinary. It's every discipline that's identified ideally for an FSP represented. Not necessarily one of our biggest deficits has been in the peer realm, which I might. And we're working to begun hiring peers that will help us address that. One of the other areas historically that we've been sort of challenged around is the employment person. Right. And again, honestly, when I think about older adults, I think about epics. Transitions are certainly the exception, and I think transitions could most certainly benefit from. I mean, all of our folks could benefit from employment specialists, but resources haven't committed for that, and so that's an area that we struggle in.
Because that kind of ties into my question about, we know that building natural social supports. I'm really glad you're going to start measuring. Those connections, and especially with step down, that community integration is what really helps sustain people in the community and have less demand on stuff. So, yeah, this was really kind of glad to hear that. One of the things that I'm curious, and I was curious about the thing about that data project. So that's going to be really, really helpful once you get those automatic triggers. I was wondering though, also looking at, it's like almost a good news, bad news with some of that data. So I'm kind of curious if law enforcement has become aware of who's in an FSP, and maybe there's less arrests because there's like some referral, or I guess they're partnering with law enforcement, and the same thing with hospitalizations. Several years ago, Mary shared an article about Mary Hafner shared an article about how when a family member is tracking discharge plans, it looks really differently. So I'm also curious that if a discharge planner knows someone is in an FSP and a colleague in a different county department has an eye on it, they're going to be a little bit more, shall we say, careful about ensuring the person is discharged into appropriate place, right? Do you have any sense of that, or?
We don't have that right now. We did just train our care coordination team on care manager, and they'll have broader access to everybody. One of the goals I think that was outlined in the data exchange project was advanced psychiatric directives.
Yes.
And improved care coordination.
Yeah.
And to be, I think we bit off more than we could chew, which is not the first time we've done that, but we have seen care coordination at this point, because we don't have a great way to ensure that somebody who's completing a psychiatric advanced directive has the all the appropriate legal approvals to be able to share that data on the other side. We haven't done it yet. I don't know if it'll be something that we try to take on, but the system is designed so that we could potentially give access to somebody at the hospital or in the jail to know who an FSP is if they've given us the legal allowable permissions. At this point, we're not even at a place to be embarking on that because it took honestly so long to get all the data partnerships in a place, and all that data has to be protected. And so there were several board letters, several approvals to get us to this point, and the project ends in June. So it won't be something that we take on with this project, but we're still hopeful that that's something that's going to be taking place moving forward. And all the partners that have worked with us for the last 3 years to get their data to us have also expressed a real interest in this. So there's certainly hope. It just didn't make sense to be pushing it when we're so newly adapted into the sharing space. And now the state is also coming forward with some data exchange parameters, which will also help to drive this moving. So there's a couple of things that are kind of converging that we were a little bit ahead of the curve on that might help to bolster this.
And so that's kind of my final thing. So I know you have Avatar, but I think in the director's report, there's with Cal AIM, there's like a new EHR, electronic health record. And like, the enhanced care management or community supports in terms of some of the services and the step downs. And so it seems like, this is why future orientations,
Yeah,
like where are we moving with that, right?
I hope so. Yeah, we are working with 21 other counties for that new EHR. So, and we all have to service FSPs and we all are required to do these forms. So our hope is that that's kind of the forefront of everybody's forefront of mind as they start to build out this new EHR. We set up care managers so that we'll be able to link that the same way that we've linked EHR for those event tracking information. But we are all it's a consensus, it's a consensus process. So we don't necessarily get to build things out the way that we would in Avatar with our own system that we can pay for the different augmentation.
Well, thank you so much.
Thank you. Yeah. We were tracking housing concentration and rest 20 years ago. 2024. So they're kind of blood instruments, and it's nice because moving forward, capturing more nuanced picture of what the consumers are like. I'm wondering who participated. Were there outside participants in developing the new metrics you can be collecting data on moving forward, or was it just the various county departments of mental health trying to just mash your systems together?
If you're referring to the new mechanism where we're going to be tracking some of their social supports, that included, I can't even tell you, it is posted on the BCBH website. I think it was well over 80 clients, family members, state organizations, advocacy organizations, and the counties themselves that work towards building out what that question we're going to look like. A lot of the challenges that in those blend instruments, so to speak, come from the state law. So we are sort of defined in that. We had hoped to make, I think, maybe more of an impact with the memo to the state in being able to adjust some of these, like one of the easiest things in my personal Hillary Carson opinion is that if you remove CATs and just have 3Ms, you have a standing measured place where you're tracking all of those path information across the board to get a more standardized approach across counties. And several other folks agreed with that. However, the state the state can't change the law, and the law is the law, and the regulations are the regulations. So we can put that information out there, but we're pretty limited in what they'll take into consideration. But as far as that one that we did cohesively decide to shift was several different stakeholders. That is all outlined in the report, but also it's not mandated. So we, as these counties, this coalition of counties, said this is so important, not only the benefits of ACT, but also to the benefits of clients doing better once they're released from this program, that we have all used, every county gets like 3 questions that you can manage and put into your system. We all agreed this was going to be one of them. So that was kind of the best that we could do with the tools that we have available to us right now.
So were there any professionals,
Yeah.
who maybe have a specialization in developing metrics such as that were brought in?
Yeah. Yes, Rand was the principal one that we worked with. They sort of did the development, and they I think they also have a report written up that has to do with how they landed on the question that they did within the forms that we have, and the space and the response and all that jazz. So yeah, it is posted on the website. It's the MHSA multi-county FSP innovation project, and that report is written from the collective perspective, not just the Ventura County perspective, and it does outline
Our website or the OAC website?
both.
Thank you. Liz Warren, followed by Mary Howe.
Mary's ahead of me, actually.
Okay, Mary.
Hi, thank you. One of the things that I came across is the January 25, 2023 report to the legislature on full service partnerships that was generated by the MHSOAC, and I'm sure that you're familiar with that. But it did talk about the importance of having metrics and data that talks about pre-FSP and post-FSP incarceration rates and criminal justice involvement, housing status, and homelessness. I see that you did provide information 2021 and to 21-22. However, I think it would be good to know what the status is of the outcome data for a longer period of time. The whole point of the FSPs and MHSA, the meat and potatoes of the MHSA is the FSP programs. And as at the press conference yesterday, they talked about how when MHSA was first passed, counties and this whole state received approximately $750 million to share between the counties. Today, we have close to $4 billion in MHSA funds to be shared by counties. So, at the same time, it's the FSP programs that's the holy grail that allows us to see a decrease in homelessness, that allows us to see a decrease in criminal justice involvement. And so I would, as somebody who's been doing this for a while and now working with a nonprofit who is coming into contact with many families who are trying to get help for loved ones, we do see some gaps in the FSP programs related to accessibility, the staff ratios, and some of these are kind of steering these folks into homelessness. So, you know, the data is an issue. If you look at the MHSOAC Transparency Suite, the 2007 to 2016 data that they were able to retrieve, Unfortunately, Ventura County ranked last in the state in terms of their outcome, their performance outcome. My hope is that between then and now, we're doing a lot better. But when I hear things like we don't have 24/7, that is part of the ACT model and one of the most important parts, because serious mental illness does not take weekends off. You need and nights off. So I would really encourage this board to take a look at the FSP programs, make sure we have fidelity to an ACT services model, and because that's how we're going to make a difference. And we've got the money. The money is there to do that. We just need the will to put it in the place so that people who are the sickest of the sick can get the help they need. Thank you.
Liz, did you have any comments?
Yeah, I just wanted to quickly say that when VCBH had their peer support program, I had I really feel like it was a privilege. I was a recovery coach with the EPICS team, and I worked with the multidisciplinary wraparound services that FSP provided. And it was just extremely rewarding, and the level of service and care provided to those high-end users of the system was really great. I think that when you look at FSPs, they are the ideal opportunity to insert peer support specialists. And especially now, if you're going to get certification and certified peer support specialists who can create a revenue stream and bill back to Medi-Cal. So I know that the department, I'm sure, is looking at all of that. I know that Dr. Shipper is looking at that, but I just want to reiterate what, as a recovery coach and a peer support specialist on the EPICS team, I was able to do, which was really help the individual with that warm handoff and the support in their next steps, if it was a step down or transition into independent living and things along those lines. I just have a quick question regarding the DCR, the data capture and entry. Do the FSPs, we used to get a census every morning. So we'd come into the department, into the office at 8 a.m. and we would have a census that would show us the number of hospitalizations and incarcerations the night before. And we would glean that list to see who was a FSP client and or a VCBH client. Does that still happen? Anybody know, Hillary, does that still happen?
Yes.
Okay, great, because I thought that was a really great tool. And I'm glad it allows you to capture stuff in real time. And I think that's just terrific. I also want to say, I know what a heavy lift this has been, the cross-county project. And I think the fact that the counties that agreed to participate in helping to refine the definitions of gravely disabled among other definitions to get everything aligned so that when you're dealing with an electronic health record and you're moving perhaps from county to county, everything has the same definition and there's a standardization that happens. I think that's just so critical as you roll out the electronic healthcare record. So I just wanted to thank you guys for the work that you're doing. And I also know that you've had I've been part of some of the stakeholder process that you've been doing when you've been beta testing some of these things. And I just wanted to congratulate you on the hard work. And just as an anecdote, I agree with you, Hillary. I think if we could just do the 3-month assessment and not have to track and update the key events weekly, that's very staff intensive work. And with the shortage of staff that we have, I think that would be probably a better way to go. And I also say that as a client, as a VCBH client, I also think that that's probably a good target. But thank you so much for your presentation. I appreciate it very much.
Thank you. Thank you very much.
All right,
Thank
thanks.
you.
So we'll go to the secretary's report and we'll table the remainder of it till next meeting.
Right, all right. Very quickly, I wanted to also say welcome to Diane McKay to the Behavioral Health Advisory Board. We're so glad that you're here. There are 3 openings for BHAB members. We have 2 openings in Supervisor Carvin's office and 1 remaining in Supervisor Morell's office, and that is due to the departure of our long-term member Patricia Malavi, who is now residing in 2 areas of California and was too difficult for her to commit to appearing in person. There's also an opening for a veteran member, but it's good to note that this position is not an additional position. It does not come out of the Board of Supervisors appointments or allotments. So it would be folded into one of these supervisors appointments, but it's not an additional appointment. And I think that there is a veteran that is being interviewed, and hopefully we will hear some good news about that. March is National Disability and Awareness Month and Women's History Month. And then the final announcement is Camarillo is moving to convert an 82-room hotel into supportive and transitional housing to help address the city's growing homeless population. So the city needs to secure a grant from the state's Department of Housing and Community Development. And I also wanted to mention that the Ventura County Board of Supervisors approved a $3.5 million grant Tuesday, contingent on Camarillo getting approved for the upcoming 3rd wave of funding from Project Homekey. And Director Gilman is not here today. I mean, not here right now, so he cannot comment on that, but hopefully he will be able to give us an update on that. And then the other is that Todd Road Jail is having a ribbon cutting ceremony, and everyone is invited. That is Wednesday, April 5th, 2023, obviously. Time 10 a.m. to noon, and the location is Todd Road Jail, 600 South Todd Road, Santa Paula, California. And that's it for Secretary's report.
Thank you. So we will adjourn this unofficial meeting. And thank you very much, everybody, for your participation, attention, insight, and patience. See you all next month. You're welcome.
Thank you, Michael.
Thank you.
Always nice to see you.